Thank you so much, Lisa and Dr. Browns, for having me give this lecture today. I'm so excited to be with you all to talk about the neurodevelopmental perspectives on nipple flow rates, optimizing safe feeding strategies. Here are my disclosures. Financial include owner of Infant Feeding Specialists. I'm Chief Clinical Officer at Nipple Care Incorporated, and I'm on the Speakers Bureau for Mead Johnson. My 9 financial disclosures include NYU Langone Hospital in Long Island, as I serve on their NICU dysphagia research team, the conference committees for both NANT and ASHA, and the Data Safety Monitoring Board for the Soothe project. And hopefully, at the end of this lecture today, you'll be able to investigate at least 2 of the normal suck, swallow, breathe neurodevelopmental milestones from fetus to newborn, relate at least one way slow flow nipples help bridge the gap between how healthy infants learn to eat by mouth when compared to how NICU infants learn, and to differentiate at least one criterion that an infant should achieve before progressing to a different flowing nipple. So I've somewhat separated the contents of this lecture today into part 1, where we really get to recognize that change is hard, but it is so necessary for what we do every day. Then we're going to kind of dip into the basics so that you feel a little bit more prepared to shift your mindset into a more neurodevelopmental perspective for the babies that we treat every day. So jumping right into it, we know that we are still learning. NICUs are only like 80 years old, and we have grown exponentially in that time. And the reason we do that is because we're learning as we go. We are looking at the data, we're looking at the research, and we're using the infant outcomes as a gauge for how we're doing and if we're doing it well or if things need to change for the benefit of these babies. And I'm really excited to be a part of this generation of neonatal providers because the information is coming lightning speed and we're constantly ebbing and flowing with that information. So I want to share, we're recording this in July of 2025. Who knows if next July this is even relevant, right? That's how quickly change can happen. And we really need to embrace it because it is truly all about the baby outcomes. So for example, in these pictures, right, we've learned not to hold babies this way. We've learned not to put babies in isolates with 100% oxygen. Why? Why don't we do that anymore? Because it didn't help their long-term outcomes. And that's what we do. We do what we do every day to ensure we get to discharge these babies to home in their families and have beautiful, thriving lives until they're adults. That's our goal, right? And so when we think about our outcomes, it really leads us to this somewhat devastating fact, if you ask me, where 45% of the preterm born infants have significant feeding difficulties in the first 4 years of life. This was done by a systematic review by Dr. Pados. And that's a staggering number. This number really does make us think that maybe we need to do something different with our feeding practices if this many babies are truly going home and having difficulties for this long. So we know we need to improve our long-term feeding outcomes. And a key step towards this improvement is fully acknowledging maybe that feeding is a developmental process. It is not a task to complete. And it certainly used to be, right? And I think we've really changed. We've really come a long way. Recognizing that feeding is a developmental process kind of puts a different perspective on it, right? We wouldn't expect a 2-month-old to start walking. We wouldn't expect a 5-month-old to speak in full sentences, right? These are developmental processes that we are really quick to accept. But for feeding, we haven't gotten there yet. But we're getting there. We're getting there. But truly, by understanding the natural progression of oral feeding development, when feeding is performed in a way that best supports long-term feeding outcomes, that's our goal. That's what we need to do. So in order to really kind of dig into this, I think we need to redefine what oral feeding success looks like. We know historically that we've lived within this very volume-driven culture where it was very much about the percentage PO, the growth velocity, and ultimately we want to reduce those babies' lengths of stay. And this is very important. And this has a place in our care and in our charting and in the way that we consider what we're doing. but it cannot stand alone. We know that when we stand alone in just volume-driven feeding goals, our outcomes are not great. And so, redefining this idea of success, I want you to shift into more of these infant-directed, infant-driven feeding goals, where it's not just about the quantity, it's truly about the quality. We want the feedings to be safe, safe against undue aspiration, but also from undue stress. We now know that stress is not benign. Cumulatively, in the neonatal period, it can lead to altered brain pathways and neurodevelopment. We want these feedings to be functional. We want to make sure that we are not overworking the energy expenditure for those babies during their feedings that could literally negate the amount of calories that the baby is eating. We also want to think about functional in terms of understanding this neurodevelopmental process. We want the feedings to truly serve as that foundation for the rest of the feeding and speech skills to grow and develop off of. So it needs to be functional. We want to make sure that we're really doing the right thing for those babies' oral motor musculature. We want the feedings to be nurturing. I mean, we love to eat as Americans, all of the cultures across the world. Mealtimes is the place where families gather for every joy, for every sadness, for every accomplishment. It is so much to do with our lives, and teaching babies to enjoy meals early is important. Allowing that to be a time of bonding for the families and that infant is so important. So we need to make sure that there's enough time in these feedings where it looks calm and peaceful and enjoyable for both the baby and the family. This is so important for the way that they learn to like feedings. Next, we want it to be developmental. We want to make sure that we're really showing up for the baby wherever they are developmentally. And this can change day to day, feeding to feeding, minute to minute. So we want to be incredibly aware of where they are in that developmental trajectory and meet them there and be respectful of that. And then finally, individualized. I promise you will never meet the same baby family dyad. And so we really want to make sure that we are taking into consideration that family's goals and their own history and their uniqueness so that we can incorporate that into our goals and really progress this family in a way that resonates with them as they are the primary caregivers for their infants. So this shift is hard and it takes a really, really long time. So some of the recommendations that I'm going to give today about how we shift into this more neurodevelopmental perspective, it's not going to be a lightning switch. It's not going to be a fast thing, but I'm hoping that we can slowly start getting our mindset there and change the culture in our units and have more respectful, thoughtful conversations. So in order to really redefine these goals, there are a couple of key things that I want to point out. First, everything we do in the NICU, especially around feedings, needs to support a family-centered care approach where we're really talking with the families and explaining to them what we're seeing and asking their advice and saying, hey, this is what I think we should do, but what really resonates with you as a family? We also need to know that our goals have to support neurodevelopmental care, right? We wouldn't ask a 2-year-old to start walking. So asking a baby to do something at a bottle or a breast that we know neurodevelopmentally they're not prepared for, it's ill-advised, right? It doesn't support that growth. And we also want to make sure everything we do supports the smooth transition to home because this baby has so much more living to do after they leave us. We want to make sure that we have set the parents up with skills and with an expectation for their baby's feedings that it's going to make the transition to home smooth. I will tell you in my practice now, I'm seeing a lot of NICUs post-discharge, and this is a real sensitive subject for a lot of these families. So we definitely want to make sure we're supporting them. And of course, it's going to require every goal moving forward is going to require strong interprofessional practice. Because what I'm sure a lot of you are seeing is that if not everybody on the team agrees on the goals, there's some contention, there's some obstacles, there's some tension, there's a lot of back and forth. There's a lot of changing recommendations, right? We want everybody on the same page. And the only way you're going to do that is by educating in a really respectful, open, non-judgmental, friendly educational, academic manner, right? And I think we lose sight of that sometimes because we're also passionate. We're all so passionate about these babies, and we mama bear these babies. But we're a team, and we have to start acting like a team. So take the time to really focus in on that interprofessional practice so that the whole unit can redefine their oral feeding success and how we're going to go on that. So now that we've kind of touched on change and that it's hard but necessary, we're going to just really quickly review the basics. And I think this is really important because it's going to set that foundation for you to really be prepared to shift into this neurodevelopmental mindset. So really quick, development of neuronal pathways, right? The babies would be growing in the womb, but they are now in our hands, right? So we need to make sure that we are promoting appropriate neurological pathways. Now, this starts really early in the baby's embryology. As early as 6 to 8 weeks, we start seeing synaptogenesis, which is the formation of functional synapses between neurons. And that's what's going to literally grow and organize that neuronal network. So we've heard through the years that saying neurons that fire together, wire together. It has everything to do with synaptogenesis and neuroplasticity. And one of my favorite theories about how this actually happens is the neuronal group selection theory. Really quick, there's three main tenets for this theory. The first one is that fetuses in the womb early on just have random sporadic movements to learn about their environment, but it's species specific, it's routed by the DNA, no real function there. But the second tenet is that as they're doing these random exploratory movements, they start saying, "Ooh, this one feels good." They start growing these sensory feedback loops that say, "I want to do this more." And it's because of that positive feedback that they start doing things repetitiously. And then that's going to start literally organizing the neurological pathways in their brain that specifically for feeding will start moving in the central pattern generators in the brainstem. Remember, all of these babies, that rhythmicity of sucking and swallowing and breathing, it all happens in the central pattern generators in the brainstem. So this is where we start seeing that connection of random movements becoming more rhythmical and more purposeful and feeling good, and the baby's desire to do them more. And then finally, this third tenet is they say, "Yeah, I'm going to do this more. I like this." And as they like it, it strengthens and strengthens and strengthens those neurological pathways. And the things that they don't like or don't have function or don't feel good, they stop doing. They prune those things off. So these neural maps, again, they continue to grow and they are going to connect perception, cognition, emotion, control, all in this very interconnected way. So it's really important that we focus on these positive functional movements for these babies to continually select and grow neurologically. And this is really nicely mirrored when we think about the development of sucking, swallowing, and breathing. We know in the womb at these really early gestational ages, babies start isolated swallowing, isolated sucking. And guess what? As it feels good, and as they say, "Ooh, this is going to help develop my digestive tract," they do it more. And now it becomes more repetitive and more rhythmical. Here we start seeing strong connections in the central pattern generators in the brainstem. It's now becoming rhythmical and pattern and predictable even. But it's not really until 34 weeks gestational age does it become a dyadic sequence of suck, swallow, suck, swallow, suck, swallow. And this is really important. This is why historically so many NICUs start feeding their babies around 34 weeks, because we need that dyadic issue, right? We need them to suck it and then swallow it straight down. Otherwise, it's not going to be alimentary, right? They need to get it into their stomach. But in order for a baby to be truly safe and efficient and proficient at a bottle feeding, or really any feeding, we need them to have good coordination of sucking, swallowing, and breathing. But that coordination doesn't come into closer to 40 weeks gestational age. They don't, as a fetus, would never have this opportunity to learn. So we really expect them at full term to have this. When we consider our preterm babies that are now potentially starting to feed around these gestational ages, we know the neurological pathways are not laid for the task of suck, swallow, and breathe. So we need to do our best to mimic what they would be doing here in the womb, because we neurodevelopmentally want their brain to learn the lessons the same way as if they were still in the womb. You see, at 40 weeks, we would expect them to have this mature sucking pattern where they can seamlessly integrate sucking, swallowing, and breathing all within 1 second. So they have the ability to take that breath and interject it into the suck swallow dyad. That is very hard. They have to open and close and open and close and open and close their airway once per second, which is, again, very energy spending, very difficult, and can be very unsafe for these babies who don't have good coordination or timing. So instead, our babies under 40 weeks, if they're born preterm, and even some of our 40-weekers, our full-term babies, but if they have any other comorbidity, they may not have the physiologic stability for that mature sucking pattern. So most of these babies in our unit, we would not expect to see a mature sucking pattern. It's really this immature sucking pattern that's the safest and most appropriate for them, for their neurodevelopment, for their ability to learn, and for their safety of their feedings. This immature sucking pattern is where they hold their breath and go suck, swallow, suck, swallow, suck, swallow, suck, swallow in those beautiful dyads that they would be doing as a fetus in the womb, and then a pause for breathing. And then they pause, they get adequately ventilated, and then they go back in for short bursts of suck, swallow dyads. All right. This could be very self-regulated and very, very appropriate for the way that they need to learn. Now, I want to just point out is while a healthy full-term baby most often do have the neurology and the physiologic stability to achieve this mature sucking pattern at birth, the truth is, and what the data shows us, is that it actually takes them a couple of days. And this is why I feel like nature is amazing, right? Our biologically normal way for a baby to learn, a newborn baby, day of life one, to learn oral feedings is with literally almost no breast milk flow. Look, this one study showed that the first day of life, it's like no flow, right? That's the mom's colostrum. It's thick, it's sticky, it's doesn't move very fast at all. So it's kind of nice because this baby is now born with only the ability to really organize suck swallow, and now they need to slowly learn how to integrate breathing. So as they slowly do it, it literally triggers mom to make more milk. And as mom triggers more milk, they learn a little bit faster how to coordinate their suck, swallow, and breathe. And then that triggers a little bit more milk production from mommy. And it's this beautiful, natural pairing for the baby to slowly learn how to integrate breath into that suck, swallow dyad. This is essentially what we need to start mimicking and mirroring in what we're feeding our babies. So when we're thinking just like a broad overview of the basics, right? We know in the womb, there's this rich sensory environment and they're exploring their environment, right? And then they're going to have this positive sensory feedback that creates the desire to repeat the movements and builds a strong neural network. And then we start seeing for suck, swallow, and breathe just isolated practice with suck and swallow, and then consecutive runs, and then a dyadic patterning of suck, swallow, suck, swallow. And then not until birth, right? If we're thinking about our healthy full-term babies here, it's not until birth do they slowly learn how to integrate breath into that suck, swallow dyad. This is the most appropriate way to think about preparing our NICU babies for oral feedings. So keeping this in mind, we're going to now shift. We're going to shift into a neurodevelopmental mindset. And we know that everything we do for NICU infants should aim to mimic the experiences a healthy fetus and full-term newborn would typically have. So this is where pre-feeding preventative care practices and slow flow nipples are essential. So, of course, our goal for feeding is to reach full oral feedings. And I think this is noble and appropriate in all of the things. But we really need to understand the foundational steps that babies in our unit must take to match their neurodevelopment from a fetus to what now we have in the NICU in order to build the foundation and to let the neurological pathways appropriately develop so that there can be full oral feedings done in a way that is appropriate for their neurological maturity and growth for years and years and years to come. So we start again with this early sensory experience. We work on just isolated non-nutritive sucking. And now as we're starting to think about dyads of suck swallow, we want to just start with some single suck swallow dyads. And then eventually some consecutive suck swallow dyads so that they can easily learn how to integrate that breath into that dyad, and then eventually full oral feedings, right? So it's this stepwise approach. And so my favorite article is done by Rachel Selman and Alexandra Popowska, where they kind of go over this habilitative approach for pre-feeding skills. So we're not going to spend a lot of time on this. Definitely check this article out. But they kind of defined the tiers to reach oral feeding. So first, we're going to have the somatosensory and chemosensory interventions, then combined sensory interventions, or what we might call simulated feeds, and then finally oral feedings. So the way they define it, these somatosensory interventions are things like massage and hands to the mouth and positive touch. Chemosensory interventions are scent cloth, skin to skin, colostrum care. And then the simulated feeding interventions are things like passy dips or Barbara O'Rourke's milk drop program, and small little paste swallows from an extremely slow flow nipple, right? Things that are really emphasized on the learning, on the coordination, not the volume. Remember, this is pre-feeding. This is before we're even worrying about volume. This is truly with the intention of learning. And it's going to be very cue-based. It's going to be where this infant is in full control. We're paying a lot of attention to their cues. We want this to be a positive experience for them. So again, really, really great. Definitely check out that publication. And while I feel like pre-feeding experiences nicely mirror the basics, right? We're providing rich sensory environment with kangaroo care and massage. Some positive sensory feedback creates that desire to repeat movements, right? We start first with isolated practice with the non-nutritive sucking, and then we start doing more consecutive runs and didactic pairings, right? So we're moving along nicely. But then we get down here to the at birth, where we slowly learn how to integrate breath into suck swallow dyads. And honestly, I think this is where we still need some help. We still need a little bit of direction to kind of get us there. And having educated countless NICUs on this topic, I frequently see the gap exists between what we consider biologically normal with our breastfeeding to what we're doing with the bottle. And I say it all the time, right? Like if you don't do it at a breast, you shouldn't do it at a bottle. And really everything that we need should really bridge this gap so that bottle feedings in the NICU are just as safe and functional, nurturing, and developmentally appropriate as breastfeedings are for healthy full-term infants. This is, to me, how we're really going to shift into that neurodevelopmental mindset. We use this biologically normal act of breastfeeding as our guiding star. So while there are many, many things that we can do to mimic breastfeedings and bottle feeding, and I love talking about all of those things, we're only going to focus right now on flow rate. And so first, what we're going to do is match the flow rate, right? If we know infants the first few days of life get like no flow, we need to make sure that we are offering babies the slowest flowing nipple we can get our hands on for their first oral feeding experiences. All right. And now, as you can see, every bottle company, in response to overwhelming positive evidence supporting slow flow nipples in babies, are now coming out with every kind of version of slow flow nipples, right? And this is great because they are learning, they're changing, they're growing with the times, and this is what we love. The problem is that every nipple company has different words of classifying their nipples, right? We have different words, we have different months, we have different signs, right? So as a provider who has the goal of educating a family to make these decisions on their own, how can I do that? That is so hard for me because new nipples are coming out constantly, and the manufacturers are changing the rubber and using different hole rates and all of these different things. Very, very, very difficult for us to know by just the manufacturing. There's no standardization. So we rely really heavily on Dr. Britt Pados in Boston to better understand the flow rates of the nipples that we have available to us. So she's an independent researcher, and what she does is she takes all of the nipples and she tests them. and then she aggregates this data, and then she's figured out that there are 7 flow rate categories, ranging from no flow, which is like a 0 milliliter per minute, all the way to extremely fast, which could be greater than 25 milliliters per minute. And so we really rely heavily on her data to help guide us in what we're choosing for these nipples and also how we're educating and providing support for the families. I will say that just last year, she changed her testing method. So now she has a more accurate method that takes into consideration both suction and compression. And you can access her data through that QR code at infantfeedinglabs.com. It is a paid membership. There are institutional memberships, but I urge you all to just go and get a membership and support Dr. Patos, because really, truly, we cannot do our job well without the dedication that she has given this field on this topic. So thank you, Dr. Patos, and please help support her so that we can use this data for years and years to come. So to bridge this gap, if we know biologically normal infants are receiving such slow flow rate their first few days of learning how to orally eat, we're going to bridge that by using these extremely slow flow nipples. Per Dr. Patos's research, we know that these are the slowest flowing nipples you can get your hands on. Currently, there are 7 different nipples in that category, but we do recommend you look back regularly because she's always adding more nipples to that data. Now, we know slow flow nipples are a great way to start oral feedings for our babies. The research is pretty overwhelming, which is why you see so many more slow flow nipples showing up in the stores and online. It allows infants to be better. It allows infants to self-regulate flow and pace themselves better, which results in increased feeding efficiency, shorter feeding duration, and quicker acquisition of oral feeding skills. We feel like it increases their feeding efficiency because they are now learning how to eat slowly without overdoing their respiratory drive. Remember, when these nipples flow very quickly, it's not giving them enough time to pause and breathe in between swallows. So because they are no longer fighting the flow, they're more regulated, which is really what they are at the breast. At the breast, they are very well regulated. They can really control that flow rate from the mommy breast. So by using the slow flow nipples, we're bridging that gap and we're seeing these increased feeding efficiencies. We're seeing shorter feeding durations because a lot of times if we're overworking their respiratory patterns, we do see that they are pausing and fatiguing, and we're spending some time during the feedings trying to wake them up again, right? Or even giving them a cat nap and then expecting them to, slowly regain their energy. And that's taking a lot of time for these babies. So again, with the slower flow nipples, they're having shorter feeding durations, and we're having quicker acquisition of oral feeding skills. They are literally learning how to eat better and faster because we are matching that timed neurodevelopment to what we're doing in our NICUs. So all good things. And I think one of the most important things to touch on is that no studies have found a detrimental effect of slow flow nipples in NICU infants. And so this is literally showing us that there's no harm in having this be their first event of feeding. It's no harm in promoting these slow flow nipples. These babies continue to ingest the same amount of milk in the same amount of time. So we are seeing repeated benefits for using these slower flowing nipples in our infants. And this is important to note because when compared to fast flow nipples, we actually have pretty well documented risks. We know that when the nipples are flowing too quickly, it increases the apneas and bradycardias these babies are experiencing. We also know that it reduces ventilation as more time is spent in swallowing and less time is available for breathing. I want you to keep remembering that these babies know how to suck. They know how to swallow. They've been practicing that in the womb for a very long time. And so the neural pathways for suck and swallow are really well established. It's breathing that is the new, complex, and difficult task for them. It's integrating that breath into that suck-swallow dyad that is the cornerstone difficulty for their feedings, right? So if we're giving them these faster flow nipples, what we're doing is we're reducing the time in ventilation because more time is spent swallowing. Swallowing will override breathing because it's a more mature neurological pathway. So if there's a nipple in a baby's mouth, they will suck because it's triggering a stronger neurological pathway. If there's liquid in the baby's throat, they will swallow because it's triggering a more mature neurological pathway. But if a baby needs to breathe, in the presence of a nipple or liquid, they can't stop. They can't inhibit that strong neurological pathway for breathing. And so what we find is that they just keep sucking and swallowing and sucking and swallowing until the point that they become so oxygen hungry that the first thing they do when they are finally able to pause is to take a big inhale. So you can see here, Martin in 1994 found that these babies had more likelihood of having a post-swallow inspiration than a post-swallow expiration. And what often happens is there's some residual liquid that's left in their pharynx that they can microaspirate on, right? So we have this natural reflex to suck, swallow, suck, swallow, suck, swallow, expirate because it clears that residual liquid. It's a natural reflex, but that ends up being aberrant or poorly timed because these babies become so oxygen hungry in the face of faster flowing liquid. We also know that fast flow nipples result in poor use of mouth musculature and can lead to an oral dysfunction. This comes directly from a lot of the breastfeeding research showing that the babies that are exclusively breastfed have far superior oral motor skills for speech and feeding in toddlerhood than babies that are fed with the bottles. And this kind of comes from the idea that, for a baby to get the milk out of a mommy breast, they need to use all of the muscles in their mouth to do that. And this is great. It's growing these muscle fibers in a really, really appropriate and rich way. But these babies are smart. They know that if they were to really suck on a regular or fast flowing nipple, they would drown. So they purposely compensate. They're so smart. They purposely compensate by either reducing their suction or only doing these little munching compression movements. And now I know you guys have seen this at times, right? These babies just kind of are munching. You're like, what are they doing? They are so smart. They are purposely trying to alter their sucking, compression, and suction so that the flow isn't so fast. This is their attempt to slow the flow on their own. And while I think they are so smart, and I'm very, very proud of them, that act of munching, it actually stunts the development of the rest of their oral musculature. And those muscle fibers don't get to mature appropriately, and therefore leading to later feeding and speech difficulties. So these faster flowing nipples, while it might feel like it's helping the short-term goal of maybe getting volume in the baby so that they can go home, it doesn't support the functional goal of having them learn how to eat the right way, the functional goal of having their oral musculature develop appropriately, right? For later feeding skills to develop off of. So really important that we recognize that faster flow nipples inhibit normal development. Slower flow nipples promote normal development. And the last two studies here show that infants use, again, these compensatory strategies like munching or that weak suck to reduce that flow rate. We will often see a couple of telltale signs that are telling us that this baby needs a little bit of a slower flowing nipple. So, for example, they might swallow a little bit of the bolus and then let some of the bolus fall out of their mouth. So these messy feeders that we are so often seeing, they really aren't messy feeders. There's really nothing wrong with their tone. They really don't have a weak suck. What we actually find is that on a pacifier, they have really good non-nutritive sucking skills. They have a strong suck. And this, again, is typical what we see. But then when we give them a bottle, all of a sudden they have a weak suck. All of a sudden we have this really messy feeder. And there are some care providers that were taught years ago that this was the problem and that they needed some cheek and jaw support. Well, that has been fully debunked. We now know that a lot of our typical feeder and growers have no problem with strength, and their sucking strengths are perfectly appropriate. It's that they are purposefully reducing their suction or purposefully munching instead of a full compression to slow that flow rate. All right, so this is what we would consider a maladaptive compensatory strategy. And it's our job to recognize that that's inappropriate, right? We need to do something different to support the baby so that they don't have to do that. Because again, the neurons that fire together wire together. We don't want these babies to learn a maladaptive way of eating that doesn't support the rest of their feeding and speech goals down the line. So again, you see babies that are very sloppy, babies that are munching, babies with a weak suck at the bottle but not on a pacifier. These are signs that the babies might need a slower flowing nipple. You'll also see a lot of bottle refusals when babies fall asleep during the bottles. These are signs, again, that they're working too hard trying to control that flow rate. You might hear babies get a little bit wet and gurgly. Also, like these are babies that are trying to separate the bolus in their throat so that they could only swallow what they can handle. And then, of course, we see this during our swallow studies, right? When we have the neonatal therapists come in to run objective instrumental assessments, whether it's modified barium swallow studies or fiber optic endoscopic evaluations of swallows, we know that one of the first lines to make a swallow more safe is to trial them on a slower flowing nipple. We know that as bolus size increases, it becomes increasingly more difficult for these babies to coordinate and to time closing their airways for safety. So again, so many risks for using faster flowing nipples that we really need to be cognizant of, because we don't want to be placing these babies at risk unless we have really, really strong rationales to do that. So while previously it felt like I have to move to this faster flow nipple, there was a lot of misinformation there. Even still to this day, I hear about some medical teams that won't discharge a baby on a slow flow nipple because they feel like it's a support or it's an inappropriate strategy or inappropriate object for them, right? And that really has to do with mindset and the education that they're receiving. They need to understand that we just had it wrong. We just had it wrong. We used to give babies that red nipple, that super, super, super fast flowing nipple, because we believed at the time that babies didn't know how to suck, that babies couldn't do that. We had to literally get the food in their mouth. And we now know that's wrong. And so the more time you take educating your team on why slow flow nipples is actually the way it should have been, and then there's nothing extra special about them except they are perfectly matched for what these babies need in terms of neurodevelopmental progressions and how they learn the act of eating. Moving on to the next main idea here is we want to stay consistent. We know that there's a positive relationship that exists between the consistency and continuity of feeding management practices and improved feeding performance. So proud of this unit here, Haynes. They're in Inova in Virginia, and they had a poster presentation at NANT, and it was such well done. What they did is they had half of them did fed only from a commercial bottle, which we know is more consistent in their nipple flow rates, and we know that from Dr. Patos's studies. And then they compared it to a group of infants that only had disposable bottles and nipples, which we know are very, very variable in their flow rate. And then they looked at a bunch of the data, and they found that the infants that used reusable bottles went home on average 3.6 days sooner than the infants who used disposable bottles because of that consistency issue. We also know that after a bottle change, NICU infants had a 75% higher chance of poorer quality feedings. So those nipple changes didn't benefit these babies. It was making things a lot more difficult for them. And then this, I think, is the most interesting part of all. Any infant with a bottle change during their NICU stay went home 2.4 days later. Think about that. When you change the nipples, we are literally creating so much difficulty for them that we're extending their length of stay. All right. So truly, we're better off staying consistent and not making too many changes. But if you have to make a change, we want to make sure that you have strong rationales for those changes. This is really key because nipple changes without strong rationales can be detrimental to the infant's oral feeding journey, right? That's not our goal. We don't want to detriment their journey. We want to support their journey and support the neurodevelopment and all of that neural wiring that is important. So when we have these rationales, link them back to some of our infant-driven feeding goals. Is me making this nipple change going to make the feeding safer for the baby, more functional for the baby, more nurturing for the baby? Is it really supporting their development in that moment? And is it individualized for what the family wants and how this infant is cueing back to me, right? Really, really important that we follow all of that. Now, I will just say a word of caution. While these goals are really well supported when you want to take a baby from a faster flowing nipple and move them down to a slower flowing nipple, this is really well supported because we know the literature tells us slow flow nipples are safer, more functional, more nurturing, more developmental, and more individualized for these babies. So that's great. But if you have a baby that's been feeding on a regular flowing or a faster flowing nipple, right, and you want to make the decision to transition them down to a slower flowing nipple, you need to allow a couple of days for them to adjust because the muscle fibers in the mouth are very prone to being sore. I don't know if you've ever eaten a New York bagel or a bag of gummy bears, right? Your jaw kind of gets a little bit sore. It's because of the muscle fibers there. So when you switch a baby from a regular flowing nipple to a slower flowing nipple, we're now asking them to use muscles that they really probably haven't worked out in a while. So, or at all, maybe. So they're not going to eat as well. They're going to have poorer volumes, poorer endurance. They're going to fatigue more frequently. Prepare the medical team, prepare the family. But what we're doing is we are creating functional improvements because over a couple of days, those muscle fibers will strengthen and they are going to start taking better volume and have more endurance. So it's a functional change that's super important for the rest of their feeding and speech goals, right? With this train of thought, I'd also like you to consider that sometimes during our instrumental swallowing assessments, we investigate different flow rates if we're seeing a baby having some airway compromise, right? So that's usually our first line of defense when we're trying to find out a safe strategy to recommend back for this infant at bedside. So we're often trying slower flow nipples. And there are times where we will try a slower flow nipple and we can see that the baby has really, really small boluses and that it might take 3 sucks before it triggers a swallow. Now, there are some neonatal therapists that might say, oh, this is actually too slow for the baby. And I that could definitely be the case for some babies, depending on their age and depending on the prior experiences of feeding. But I just want you to consider the fact that maybe now at this point in the study, they're already fatiguing and perhaps they don't have the oral musculature yet to adequately feed from that slower flow nipple. Right. So kind of keep that in the back of your head. I know even sometimes at bedside, I'll see a baby and I'm like, oh, let's just see at bedside here. Let's try a slower flowing nipple. And I see that the suck to swallow ratio is really high. I might even say, let's just try this for 2 days to see if the baby can build that oral musculature. So really important that we're thinking about the function and how that's going to affect what we're seeing at bedside for those infants. Now, the decision to move up in flow rate, right, from a slower flow nipple to maybe a little bit of a faster flowing nipple, that the rationales there are a little bit more nuanced. So I've kind of come up with these criteria, if you will. We're going to assess the criteria really, really, really objectively as we can. 1, has the infant been coordinating suck, swallow, and breathe by demonstrating an immature sucking pattern? If they're younger, if they're a little older, then we would look for the mature sucking pattern. Without the need for a lot of pacing, we know that the higher flows need more pacing. The lower flows need less pacing. Pacing is prone to human error. It stresses out a lot of families sometimes. So we want to eliminate pacing if we can. So that's why we like these slower flow nipples. And we want them to do this without any stress or cardiovascular events at bedside. That's 1. 2 is we want this to have been established consistently over a period of time. So there's no arbitrary number here. It's going to be infant directed and it could be, I don't know, it could be a day, it could be 2 days, it could be a week. Who knows? It is up to the baby. It could be a month. It could be no change at all. Because the truth of the matter is if it isn't broke, don't fix it. There is no evidence suggesting that infants need to advance nipple flow rates. This is the goal. If we have a baby that has a good coordinated suck with not a lot of pacing, with no stress, with no events, and they're doing it, and they're gaining weight and their percent PO is slowly improving, we're here. We've done our job. This is beautiful. This is what we want. So if this is where we are, don't feel so quick to run off and make a change to that. I'd like you to consider that for some infants, a slow flow nipple really might be hard for them. It may not be appropriate for them. Maybe that extremely slow flow nipple was great for those very first early oral feedings. And now, as their oral space gets larger, as their coordination gets better, as they're growing and getting more strength and stability and autonomic stability, maybe they do need to go to a very slow nipple, and this is appropriate. One thing that we might see is where they were originally nicely coordinated and have been doing this for a minute or so, but now all of a sudden we start seeing many sucks to swallow, like maybe 3 or 4 sucks to one swallow. That might be a sign that the baby is strong and is doing a good job extracting liquid, but even with his strength and his level of neurology, the bolus size is still too small to trigger one swallow at a time. So ideally, we want suck, swallow, suck, swallow, suck, swallow. This is an efficient immature sucking pattern. Even if it's a mature sucking pattern, it's suck, swallow, breathe, suck, swallow, breathe. Ideally, we like this 1-to-1 ratio. But if the flow rate is too slow for a baby consistently over the entire feeding, you would see like 3 sucks to a swallow while they're trying to gather the bolus in their mouth to trigger the pharyngeal swallow. So we want to kind of keep that in the back of our head. That might be a sign, but it really probably needs to be assessed by the neonatal therapy team. It's a lot more nuanced than just looking at some of the other criteria that we're going to have here. But all of a sudden, you see that the infant's percent PO has plateaued over a couple of days, or all of a sudden they start showing some signs of stress or frustration or fatigue. This is the rationale to progress to the next category flow rate per Dr. Pitos's data, right? This is the rationale. Their PO is plateauing, or they're showing this new sign. And then we also want to make sure that before we make any changes, the fourth criteria we have is, have you done this little bit of a criteria assessment, and have those recommendations been shared with the family and the medical team? Because we need, it's not a suggested, it's not like cherry on top, we need family-centered care and interprofessional practice approach. We need that to support our babies the right way and their families. So if you've done all of these things, check, 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 great. Give that new nipple a try, right? That's the fifth one. Try the new nipple. You want to make sure you're working around the family schedule so that you could be together to try the nipple. It's a great opportunity to teach them cues and educate parents on what to look for, because at some point when they're home, they're going to want to try a new nipple. And we want to make sure that you've taught them what to look for, right? So you're trying this new nipple, but if the infant is showing signs of stress or incoordination that's not easily improved with pacing, then consider switching back to the other nipple, right? There's no evidence that says you can't do that, right? Or that you have to increase the nipple flow rate. There's no evidence to say that. So give it a try. And then you could always try again in a couple of days if your rationales are still present and still valid. But we're going to be taking, again, this very, very cue-based, infant-directed approach to this trial. And again, we have to make sure that we have the family incorporated in that as best as we can. So some takeaways for you all today. I always want you to look at that risk to benefit ratio when considering which nipple flow rate we're going to offer a baby. Ideally, I'd like you to link that selection to where that baby is along their neurodevelopmental timeline. If it's a skill or a set or a movement or a milestone that they would be achieving as a fetus, that's what we want to mirror at bedside. We want to follow that normal progression for them, because it's the process of learning that we're supporting, not a task. It's the process of learning. We want to make sure that we're avoiding frequent changes. We know that these are not supporting the infant in a positive way. And while we are considering these changes, we want to assess that criteria to see if maybe a change is necessary. And of course, those strong rationales. We have to make sure that everything we decide is linked back to an infant-driven goal, that it's going to make the feedings better for the baby and not just a volume-driven goal for that little one. Of course, we always want to ensure the families are being incorporated into the thought process, the decision making, that they fully understand and are being educated in a way that not only supports them while they're here in our units with us, but that really increases their confidence and competence once they get to go home and make these decisions about their baby without the luxury of 24/7 care from highly specialized neonatal providers, right? Interprofessional practice is key. This change, right? This doesn't come easily. This is going to be hard. A change in perspective, a change in the culture, it's necessary. We have to do better for these babies and their long-term outcomes, but it doesn't necessarily work if only one person believes it. We need the whole unit to get there. We need to really lean into interprofessional practice. We need to have these conversations. We have to bring everybody to the table and explain the literature and explain the neurodevelopment and ask their opinions and see if they can provide us with other rationales and make a guideline, make a protocol, put this down in stone. There's so much good to happen, but you can't do it on your own. You need your team with you. So please lean into this interprofessional practice approach when trying to institute any of these changes, and embrace that change, right? We need it. These babies need it. We can do this for them. So I hope you all learned so much today. Thank you so much for being with us to learn about these really important and valuable perspective on neurodevelopmental care, as it relates to nipple flow rates. As you see, I love talking about all things babies and bottle feeding and breastfeeding and development, as well as NICU culture and professional practice. My email is down here, so if you have any questions from afar, I'm always happy to help. And I am so excited to start the Q&A portion of our lecture. Thank you again for having me.
The one thing I did want to mention to everyone is that it seems that some people can download the slides, some people can't. I know that hospital computer systems sometimes will forbid people from opening any links. So when you receive your CE information in that email I was talking about later today, you will have the slide like in a PDF that you will be able to open. It won't have to just be a link. So you'll actually have the PDF. So we will get those slides to you. All right, welcome back. As I said, it's so great to have you back again after being our first webinar presenter. So thank you for being with us in the long haul.
Always.
Let's see, there's some great questions. So, and this is so involved. It's about culture change, but about, how you're talking about, we have to work on this together. Do you have any recommendations on how to have a brief discussion with nurses when they ask about increasing flow rate? Great question.
Yeah, this was a great question. So I think, we're faced with this big change in our units. Remember, the nurses that we are working with, a lot of times they were literally educated that babies didn't know how to suck and that we had to help get that liquid in their mouths. So for them, I think just knowledge is power, sharing with them the literature, letting them know that these babies aren't doing great, and then kind of pulling it back to the neurodevelopment. I feel like culturally in the NICU, we are so pounded with breastfeeding, and the benefits of breastfeeding. But I think if we pull bottle feeding and make it more similar to breastfeeding, I think that gap, I think nurses actually really get it. So if you kind of replay this information for them or share the link after it goes on the webinar platform, education is key. So just giving them this perspective and saying really openly with this real idea of interprofessional practice, saying, what do you think about that? What are your concerns? How can we have a really rich conversation about it so that we can all get on the same page for the benefit of these babies? And you know what? It may not be the criteria that I shared with you today. Maybe it's something completely different, right? But make it make it a unit-wide decision, make it really true and applicable to the uniqueness of your unit and the people that are there. So, but you have to have those hard conversations. Definitely don't do it at bedside after a little tip about what nipple you're going to do. Maybe invite them to a meeting, have some coffee, and make it a lot more team building instead of me versus you.
I love that. And I also know, we talk a lot. We did a feeding together call a few weeks ago where we talked about this and collaborating with nurses. And historically, I'm old enough that we used to do this rehab model where speech would come in, they would make reservations or recommendations and leave. But with the model of what's all integrated together, let's sit down and feed the baby together. Like that's a luxury, but let's sit down and do it together and have this language where we're talking back and forth and communicating. And what do you see? Well, what do I see? And you having the same language, I think, is so important. So, um, oh, this is another great question. The criteria that you were providing, does that apply for infants followed discharge from the NICU from transitioning to maybe level 2 or 3 or as you're going up, or only criteria for slow nipple rate changes? And this is in regards to, because this person has lots of NICU grads asking about when to bump up that nipple change.
Yes, I love that question. So absolutely, you can use certainly number one of that criteria, right? So you're going to be educating the families before discharge. Say, hey, at some point you're going to go home and you're going to want to try a next nipple up, right? And that's great. We want you to have the autonomy to look at your baby and say, ooh, this is what I'm thinking, and then give it a go. But let's see if we can follow these guidelines. First, you want them to have a well-coordinated suck, swallow, breathe pattern. So assuming it's an older infant, you're going to be educating them on a mature sucking pattern, a 1-to-1-to-1 suck, swallow, breathe ratio. So that's important. You're going to want them to have that coordination without any stress. And at this point, I would hope the family is really well educated on what stress looks like for their baby. If not, this is an excellent opportunity if they say, oh, what does that look like, to really provide some education. So you want a well-coordinated sucking without any stress and without a lot of pacing. All right, because again, we lean into pacing and it is such a beautiful strategy to use for our families, but it's user dependent. Maybe mom does it differently than dad. And then certainly trying to teach that to a nanny or a grandparent that might be helping around, right? So of course, caregivers, it can be kind of prone to human error. So by using these slower flowing nipples, we know we don't have to pace as often. So again, coordinated sucking without a lot of stress, without a lot of pacing. And if you've been doing this for a couple of days and you feel like baby might be ready for a change, give it a go. Try. And if you feel like baby's all uncoordinated again, go back to the other nipple. Remind them that there's no evidence to say that they have to scaffold up, every 3 months or when baby starts crawling or walking, right? They have all of these different ideas about when babies might need an increased flow rate. So just provide them that the first two criteria, right? Over a little bit of period of time. Because if they are coordinating well with no stress, with not a lot of pacing, don't change. That's perfect. They're doing exactly what we want.
Thank you. This is a classic question that I think is we hear all the time as a therapist. So I often hear from nursing that the baby is working too hard, collapsing the nipple, and therefore needs something faster. How would you recommend addressing these comments?
Yeah, another really great question. You guys are asking amazing questions. Thank you so much for being so engaged. So I think this kind of comes back down to our goals, right? And this is like the classic nipple flow rate debate, right? There's like the short-term goals of feeling like we have to get the volume in the baby so that we can get them home. And it's a absolutely valiant and appropriate and well-intentioned goal. But sometimes at the risk of their short-term goals, such as safe and functional and all of that. So I think this question specifically worries about function, right? Like, well, if it's so slow and baby is fatiguing and burning so much energy, how is it functional, right? So it will depend on the age of the baby and their prior eating experience. We know in those really early feeding weeks, like 34, 35, 36, 37, right? I'm okay with this baby fatiguing because they're going to fatigue. The act of eating is hard, but we are building muscles that they need. So it ends up being more functional than it is fatiguing, which is a great win for these babies. But if you now have a baby at 41 weeks and they for a while were doing great and now are all of a sudden fatiguing, yeah, that's a great sign that maybe the baby does need to go up in a nipple flow rate. But it's not something that can be easily identified at one feeding, right? You're going to want to see that pattern. You're going to want to see some consistency with the concerns. And that's how you're going to have a valid rationale. That's the valid rationale that you're going to go back to the family and the team and say, this is what I'm seeing. I'm seeing this now over a couple of feedings, a couple of days, and I'd like to make this switch. Mom, caregivers, family, what do you think about this? Bedside nurses, let's look at your notes. What are your documentation on all of this? So that you can come to the table together. I often, when I give lectures like this, I often get the question like, well, what about for a cardiac baby? Like, these cardiac babies are going to fatigue. And it's like, yeah, you're right. This cardiac baby is going to fatigue, but don't cardiac babies also deserve to have really good oral motor development and speech skills when they're toddlers? Right? And the answer is yes, they do deserve that. So even slow flow nipples for our most likely to fatigue population is still functional for them in those earlier feeding windows.
Yeah.
I'm looking at the picture. I just want to make sure I answered the question. Prolonged feedings. Again, like if the goal of the feeding is to get the volume in the baby as fast as possible, that's not a functional goal. Why do we think we have so much reflux in our units, right? These little teeny tiny little baby bellies aren't designed to get a large volume in their stomach quickly. If you took that same baby and fed them at a breastfeeding, you'd see there's a slow trickle of milk into their digestive systems so that we're not getting a lot of gastric distension and therefore not getting a lot of reflux. So these slower flow nipples are actually appropriate for their digestion and how it would be biologically normal for liquid to go into their stomach. So the fact that it's prolonging the feeding is much less important to me than the quality of that feeding.
Yeah. And I think that, the one person who said working too hard, because we hear that a lot, that I don't want to use a slow flow nipple because slow flow nipples, there's a misconception that it makes babies work too hard. And Catherine Shaker has some great articles about actually, first of all, as you mentioned, there is no research that says slow flow nipples, harm the babies. But when we support a baby with their skills and match the nipple flow rate to their skills so that they can have a beautifully, the coordinated suck, swallow, breathe, that actually is more supportive for their endurance. If we're giving a baby a high flow nipple and they're working harder to breathe, that is what tires babies out inappropriately. And, not just normal fatigue, but that puts a tax to their system because they're working too hard to coordinate suck, swallow, breathe. So I think that may be what that person was referring to. And I know the articles by Catherine Shaker really, they really have a really great language for explaining that. So you could give this person, if you're looking for, articles, you could give them those articles by Catherine Shaker as well.
Yeah, anything written by Catherine Shaker is great. And she references a lot of the evidence that I provided in that one slide about benefits of slow flow nipples. So
this is really just a statement, but I think it's a really great statement that somebody said this. So I'll let you expand on it. It's not really a question, but somebody was just saying that, they have their hospital has a certain brand, but families, whether they can afford them or not. And the statement, we need to include the family in the decision of what nipple to use if they have a specific supply at home.
yeah, it's so true. And so this is why those conversations and making sure that it's family centered is important because, if we're following the data, we know as of right now, there's, let's say 7 nipples that are in the extremely slow flow category. I think there's like 13 that are in the very slow flow category. So this is great data to go back to the family and being like, hey guys, this is where baby is at right now. And maybe we are only using Dr. Brown's, or maybe we are only using hospital grade nipples here, disposable nipples here in the unit. But when you go home, this is the category that most links that. So we're safeguarding their transitions home. So try to find a nipple that's on this list that is the same flow rate as what the baby is doing now. So call your friend, call your sister, call your neighbor, say, hey, what bottle systems did you really like with your babies? And then see if you can find a nipple on that list that is matched to what the baby is being successful with, and seeing if that's within their cost structure, and seeing if that is something that they are interested in using, right? So don't feel like just because they're using one thing in the NICU, it doesn't mean that we can't still support them at transition to home. There's absolutely a way for us to safeguard that. In our unit, years ago, we used to share a lot more of this, Dr. Pedos's data. And we saw a significant decrease in readmissions for bruies at home, because these babies are maybe on a slow flow in the NICU and then go home, and the parents are trying these like super fast nipples. Well, guess what? That's going to trigger an ACE B or D, but without a monitor, right? That's called our bruit. And then these parents get so scared, it's a re-trauma. They have to get re-hospital. Like, what a nightmare. So if we can really give them the few nipples that flow in that flow rate, give them the autonomy to talk to their friends and family about choosing the one that works best for them and their family needs and their cost structure, we can really just do a better job getting these families home without the risk of readmission.
Yes, thank you. In your reference list, which we will provide that in addition to the handouts, do you have any literature that demonstrates about the breastfeeding connection to improve oral motor and speech function? Do you have those references in that reference list, do you think?
Yes, so if it was in a slide, it's on the reference list.
Okay. We'll double check and make sure that we get that to everyone. There was a question about pacing. When you're pacing a baby to improve their overall coordination and safety, how would you recommend identifying whether the baby is actually needing pacing for coordination versus the baby taking multiple sucks for a bigger bolus to trigger the swallow reflex?
Okay, this is another really great question. So, with the knowledge that babies' primary difficulty is with breathing, right? They know how to suck, they know how to swallow, practicing that in the womb since very early gestational ages. It's integrating the breath that is often the complex and difficult task for them. So when I am feeding a baby, I am paying a lot more attention to their breathing than to their actual swallow sounds. I'm listening to the swallowing sounds too, but that breathing is really kind of letting me know how that coordination is going. And that's what I worry about the baby having a difficult time with. So for me as a feeder and as I'm educating the family, I'm having them listen to the breathing to see if all of a sudden it gets a little bit more increased work of breathing. I'm having them look at the accessory muscles in the neck and the tension in the face to see if this baby is working harder for inspirations. And I find that I'm pairing that with their facial expressions and the tension in their body. And that's the cues that I'm using to pace. Because pacing, the real task of pacing is to impose a break so that they can adequately ventilate to improve their coordination. That's the main goals for me as a pacer for that baby. So to me, I am paying a lot more attention to the breathing for the pacing. So now if instead I saw a baby taking multiple sucks to get a bigger bolus, babies can breathe and suck at the same time. They can't swallow and suck at the same time, but they can breathe and suck at the same time. Usually in the mature sucking pattern where it's suck, swallow, breathe, they actually suck, inhale, swallow, exhale. But that suck and inhale happen simultaneously. So I'm usually not worried about breathing or needing to pace for the baby that's doing a suck, like let's say 3 sucks in a row and then a swallow and then a breath. I wouldn't pace a baby for that. And then that will be the sign that maybe this baby is over fatiguing or truly unable to use their oral musculature to draw out that bolus, and maybe do need a faster flowing nipple. But I would give that baby a couple of days on it to have the opportunity to grow those muscles. I don't know, Lisa, did I?
No, yeah, and I was going to say too, because it's so much about looking at the whole baby and the cues, overall cues, and so many of those babies have those subtle stress cues earlier on, so the face and all that. So
Yeah. But it's like, as you said, it's that whole picture, because if a baby is breathing fine and just has an eyebrow raised, I then have to say, okay, how is that swallow sound, right? So there's a lot of things that we're assessing. It's really truly what I see, what I hear, and what I feel with my hand.
yeah,
And that, yeah, and that's going to make those decisions. But if I'm just seeing more suck to swallow ratios, again, that will present differently, and I would do something different.
And we know, like you talked about earlier, sometimes babies, if the flow is too fast, they disengage from all their suction because it is too fast. So they're reducing that and maybe only doing small compression. But
Yeah.
you touched on something about time, because we know there is no cookbook, but people are talking about how long before advancing from a preemie to a level T. So maybe just clarify that statement, because it says, how long would you use a preemie nipple before advancing to a level T?
Yeah, so it is completely infant driven. There is no arbitrary number that we can place on any of this. There will be some infants that will get discharged on an extremely slow flow nipple. There are some babies that won't, right? And this is completely up to them. So we're going to use this full team approach, because as neonatal therapists, I'm not there at every single feeding. And even as caregivers, as mom and dad and, aunt and uncle and grandparents, they're maybe not there at every feeding, and not every nurse is there at every feeding. So you really do need to talk to the whole team and say, this is something that I've been seeing. What have you been seeing? If it links up, that might be an assessment for your time. And then certainly if it's going to be a baby that's getting ready for discharge or who's already discharged home and you're helping them, just ask the parent and say, guys, what's your instinct? Do you feel like baby's getting frustrated? Because baby was doing really well. They were coordinating, they were taking good volumes. Do you feel like they're not progressing? Because if that's your concern as a kind of like a lay person to all of this, let's give it a shot. Let's see. Let's look at those facial expressions. Let's look at the body language. Let it be very infant directed. And then if it's not working for them, we'll go back. And that's okay for us to try. But we have to have the very valid rationales. It can't just be the parent saying, well, I want them to eat faster because these feedings are 30 minutes. That I may not support. Or I may try to very gently say, well, that is kind of normal still, right? But let's give this faster flowing nipple a shot. And then you tell me how the baby's quality was. And let that be a feedback loop for the family to better communicate with their infant.
Yeah. And I know people will often say, the providers or whatever say we can't go home on this very slow flow nipple. And as Dr. Lisa has mentioned, there's no research to support that. And in fact, very clearly, one of Dr. Patos' article talks about that. So if you need any of these resources or references, please reach out to us and we can get that for you so you can have support to talk to your staff. I think, this is a very interesting question too. Because infants receive such small volumes in the beginning of breastfeeding, would you recommend starting with smaller volumes in addition to a slow flow?
I think biologically normal, these babies are going to self-regulate. But because we are now comparing that to a preterm baby or a medically fragile infant, I think we're just going to follow their cues, right? So let's just say the medical team has determined that they need 10 milliliters every 3 hours as part of their daily oral or daily requirements. And let's say you're sitting down with this baby and it's their first feeding and you have the family there and you're using an extremely slow flow nipple. If they take 3 mLs, I think that's great. As long as they had the opportunity to learn and it was positive. Again, we're trying to move away from this idea of volume. We're going to let the parents know, hey, mom, they could have taken 10, but they took 3. Can you believe they took 3? That's amazing. And we're going to make them feel really, really good of the fact that they did it calmly. Yes, okay, maybe I had to pace them a little bit, but this is them learning. This isn't a task for them to complete. This is part of the learning, and they're going to probably take small volumes by mouth as they learn. And that's great. So really focus on that quality for them, but let them gauge themselves, because you may get a really rowdy 35-weeker who wants to take the whole 10 mLs. And I think that's great too. But it's going to be based off of the infants and their cues and all of the signs of physiologic stability that we would expect to see for a baby who wants to either continue feeding or to stop feeding.
Yeah, and that leads into our last question. A lot of times too, those babies, before they start bottle feeding, they've almost had that, we're giving them drops a lot of times. So they almost have had that a similar experience to the colostrum. But that leads us to our last question because we're talking about things we're doing first and pre-feeding. So many times we tell babies can't PO feed. They're not ready to PO feed, but we say, what are things we can do? So all the positive parts about it. And the question is about the pre-feeding and all the newer research is coming out about activities for pre-feeding. So are there any that you would recommend or some of the studies that you like better than others? So what would you recommend?
Yeah, this is great. So that article that I had showed by Selman and Popowska in 2024, they do an excellent review of all of the studies with their references there. So absolutely take a look into that. And one of the pre-feeding things that I think is like concern sometimes is following set protocols. So there's actually some really strong research about following the protocols in terms of length of stay and oral feeding and latching for breastfeeding and all of these really great things. The only word of advice I will give you in terms of how I use those protocols myself is I will not do anything to an infant unless I have a very, very, very valid rationale. So I tend to not follow any of these protocols beginning to end, and follow like, okay, first you do this and then you do that, because not every baby is going to need the those particular, especially like oral motor exercises. For example, never in my NICU experience have I ever needed a baby that I needed to do this to, right? And so I know that's a step in some of those oral motor protocols. So if it's not something I know this baby needs, I am not going to do it, whether or not that protocol says to or not. And I encourage all of you to think about it that way. We have to be incredibly intentional. Everything we do to these babies are wiring neurological synapses and neurological pathways. If it is not neurodevelopmentally appropriate for them to have that experience, we shouldn't be offering it to them. Now, granted, they're in the NICU and we have to save their lives and grow them and do all of the things. We're already doing enough, right? But when it comes to really trying to help their oral motor, we just want everything to be as functional as possible. And I always joked, and I would love to do this in hypothetical land. I don't know if an IRB, well, maybe they will, but I, I would love to like get cohorts of babies and have like one cohort of baby follow, I don't know, the Piomi, and then another cohort follow Fucili's, and then the other cohort follow Kamisuka's protocol for oral motor therapy. And then I want the fourth cohort to be a cohort of babies that just got positive touch to their face, held with positive touch to their face. I bet I wouldn't be surprised if they do just as well as any of the babies in those other cohorts. Because I think that's actually probably the guiding link, is that these babies get extra time in someone's arms. They get extra time staring into someone's eyes. They get extra time with touch. I think the power of touch is so magical. So I wouldn't be surprised if the babies do just as well just with touch.
Thank you. It's a great explanation. We know that, I mean, they say kangaroo care has the most research of anything in the NICU. So
Yeah.
lots of great questions. Thank you, Dr. Louisa, for being here. And we thank everyone for being here, joining us, staying on for the Q&A, because this has been such a great conversation. So we will send the CE information today, later today. I say give us 24 hours, but sometime later today. It'll have the CE information, your links. It will have the handouts that you need. And we'll have another webinar sometime in the fall. So we can't wait to see you all then. So thank you all for being here. But before we go, I wanted to just mention one quick thing from Dr. Brown's Medical. Dr. Louisa talked a lot about infant-directed feeding, cue-based feeding, and she also mentioned infant-driven feeding with the goals of feeding being safe, functional, nurturing, developmentally, and individually supportive. And Dr. Brown's does have the infant-driven feeding program, which is an online educational program that all your staff can take to be consistent, have the same language, and learn how to promote positive feeding experiences and change your culture from volume-driven culture to infant-driven feeding. So if you have any questions about that, please reach out to us. You can email anyone to Dr. Brown's Medical. You can go on our website at drbrownsmedical.com or go to medinfo@drbrownsmedical.com and email us. All right. Thanks, everyone. Again, thanks, Dr. Louisa, and we'll see y'all later. Thank you. Bye-bye.